Welcome to this series in Pathways in Diagnosis. This is webinar number 3. The purpose of these webinars is to introduce you or to help you to incorporate OCT into your practices for better detection and management of patients with different ocular conditions. I'm Dr. Julie Rodman, and I'm going to walk you through this presentation on optic disc edema. Again, we're going to talk about how we can best use OCT in our practices for various ocular conditions. In this particular webinar, it'll be optic disc edema. So the question always is, how can I use my OCT to the best of its ability? I have it in my office. I know that I can use it for retinal disease. I think that when we're in school, we always think about OCT for retina and perhaps for glaucoma, but I don't think that most practitioners are familiar with how you can actually use OCT for other conditions, okay? Diseases of the optic nerve, in particular, diseases where there's maculopathy from toxic effects, other things like that. But in this presentation, we're going to focus on optic disc edema and how you can use this technology. We're going to look at retinal thickness maps on these patients. We're going to look at ganglion cell information on these patients. And we're going to put together a whole picture on the patient before we even see them using some preemptive screenings from the OCT. So I put this picture into each of the webinars because, again, I have to emphasize the importance of understanding the structure of the retina and what it looks like on OCT so that you can discern what normal versus abnormal look like, okay? We all know that OCT is a very easy test to do. You sit the patient behind a machine and you essentially take a photo. You can get multiple photos in seconds of time, which is always very nice. It's a non-invasive test, okay, so we don't have to worry about patients having side effects from dye or anything like that. Patients won't have anaphylaxis to the test. It uses light waves to essentially obtain a tomogram or cross-sectional image of the retina. So what you can see here on the top right is what a B-scan section or a cross-sectional image of the retina looks like. The black space on top is your vitreous, and then we go further down posteriorly through the layers. We have our nerve fiber layer, our ganglion cell layer, then we have our inner retina, which is our inner retinal, inner nuclear, the outer retinal tissue, which is the outer plexiform and outer nuclear layers, your external limiting membrane, you have your IS-OS junction, which is the inner segment, outer segment junction of the photoreceptors. You have your retinal pigment epithelium, which is your hyperreflective bands, and then your choroid. And we talked a lot about in the previous webinars how different disease processes will affect different layers of the retina. You're probably thinking, well, what about a disc problem? How would optic disc edema become affected? Remember that the nerve is part of the back of the eye. It's part of the retinal space. And when the nerve becomes affected, the peripapillary tissue becomes affected. And it also affects the ganglion cell tissue. Remember that the ganglion cells, or the ganglion cell complex, is made up of the ganglion cell tissue, which is the inner plexiform, nerve fiber layer, and ganglion cell layer. These house the dendrites, axons, and cell bodies of the ganglion cells. So essentially, if any of those are affected, your ganglion cell complex will be affected. So there's been a lot of literature done on what happens in situations where there's damage to the nerve, right? Because if there's damage to the nerve, then there's going to be damage to one of those parts, either the cell bodies, axons, or dendrites, and your ganglion cell complex will be affected. So let's talk about how this works. And on the bottom of this slide, I show here how the OCT correlates histologically with each layer of the retina. So here we go to the first part of this, what we're going to call rubric that we'd like to present. And it's incorporating the use of your technician to the best of their ability, okay? We're going to teach them how to take an excellent patient history depending on the disease process that we're talking about. And I mentioned in the previous webinars, and we'll go through this again, that a patient that has optic disc edema, we're going to emphasize different things than we would emphasize in a patient that had diabetes, perhaps. So the technician has to know exactly what questions to ask depending on what we're looking at. And you might not know when the patient's sitting in the chair at the beginning of the exam why they're there. In fact, the technician's most definitely not going to know. But depending on the patient's symptomatology, there are certain parts of the exam or of questions that we need to make sure we cover, okay? The patient's medical history is crucial in these patients. Okay? And even if you go back, let's say after the technician has already finished with the patient and obtained these answers, that's fine. The goal is that you get all of these questions answered when you're making the diagnosis. So in the patient's medical history, we want to look at the systemic conditions, okay? We want to find out about hypertension. Remember that a patient that has malignant hypertension could present with bilateral optic disc edema. So it's very important that that's part of our workup, okay? That we understand if the patient does have high blood pressure, is it being managed appropriately, okay? Have they ever had nutritional deficiency? Okay? Patients that have had a nutritional deficiency are known to develop things like toxic amblyopia, which affects the optic nerves. So we want to ask the patient that. What about a nutritional problem? Okay? Have they ever had a time in their life when they were not eating properly or they were severely ill and they didn't get the proper nutrition? That could definitely cause the nerves to be abnormal in appearance. So we need to ask those questions. Then we move on to the neurologic system. Are they having headaches? Okay, remember, patients that develop optic disc edema are going to report a different kind of headache than their normal headaches. The headaches are worse upon awakening, worse when they cough, worse when they bend. So those are specific things that you want to ask them. It's not just your normal run-of-the-mill headache. Okay, we need to ask them about these postural changes. What about nausea and vomiting? Unless the patient has migraines, we don't usually consider a headache with nausea and vomiting. That would be a very significant type of headache. What about tinnitus, ringing in the ears, whooshing sounds in the ears? Those are very common with optic disc edema. Okay, so those are very important questions to ask, and probably some of the most important. What about the ophthalmologic questions? Does the patient have decreased vision? Okay, papilledema in itself doesn't usually cause decreased vision, but the patient may report some type of visual obscuration. Do they have diplopia from a cranial nerve palsy? Is there entrapment from elevation of the nerve tissue? Is there impaired color vision? Again, papilledema, the color vision is usually normal. Okay, so these could help us ride the exam in the right direction. Okay, what about the patient's lifestyle? Have they reported a recent weight gain? Have they been pregnant? Okay, because those things, again, are associated with papilledema. So if we don't ask those questions, we can't use that information to guide our exam. This is not a complete chart, but it's the chart that I like to refer to when I'm looking at disc edema. I like to separate it into the unilateral cases and the bilateral cases. Okay. In the unilateral cases, we think about things like optic neuritis. Okay. Again, history is so important. It happens more often in young females, 20 to 40. Okay. What about an ischemic optic neuropathy? Happens more in elderly patients with microvascular disease. What about an orbital tumor, right, which we would have to diagnose based on symptomatology and imaging? Okay. And then we think of the miscellaneous ones like a tumor or Leber's or a vascular occlusion. Okay, but that would be more of the unilateral set. The bilateral side would be things like malignant hypertension, which we talked about. When we think of systemic conditions, they usually affect bilaterally. Okay, so if it's a diabetic papillopathy, it's going to be on the bilateral side because it's a systemic condition, just like high blood pressure. And then we go into the realm of papilledema, and that's a huge realm. Okay, all patients with papilledema are going to present with increased intracranial pressure. The question becomes, is the increased intracranial pressure benign? Is it idiopathic? Or is there an underlying disease process? If there's an underlying disease process, I put a few of the etiologies up there. It could be hydrocephalus, it could be a hematoma, an abscess, an intracranial tumor. Or it could be an idiopathic intracranial hypertension, which we would call pseudotumor. And pseudotumor in itself has its own risk factors like medications, tetracycline, oral contraceptives, nalidixic acid. So depending on what we're suspecting, we want to get those questions answered. Okay, and then again, we talked about the miscellaneous items, toxic amblyopas and things. So this is essentially the flow sheet that we want to refer back to try to make it easier for us when we're working through the diagnosis. We're going to have, after we've obtained the patient's personal history, and we've gone down that outline, and we're trying to isolate certain things based on color vision, based on symptomatology, we're going to move on to family history. We don't necessarily think about optic disc edema being a familial disorder. Okay, this is more of something that attacks an individual on their own. But you always have to think about the zebras, like things like Leber's or another hereditary disorder where the optic nerves would be affected. But again, it's not on the top of our list of things that we would think about as being inherited. Once we've obtained the histories, we talked a lot in the previous webinars about getting our screening OCT. Okay, and the screening OCT is going to give us great information because if the condition is acute, it's going to present one way. If the condition is chronic, it's going to present another way. So you have to understand that these conditions are not black and white. And I'm going to try to go through examples in this webinar of acute and chronic situations of optic disc edema. Because the screening OCT gives us some information, but it's not going to give you the whole picture. You're going to have to move forward and kind of hone in on the test that you want to do to help you arrive at the final diagnosis. So once again, this is a printout of a screening OCT. I've gone through this on multiple times. We'll go through it one more time. This is an OptiView Eye Wellness printout. I like it because it shows us everything on one printout, but you can use the Cirrus or Heidelberg as long as you're getting all of the information that you need on that initial printout. So on the top here we have our B scans, which are essentially our cross-sectional images of the retina, and they look completely normal in this patient. Then we have our retinal thickness maps, which look completely normal. Remember, they're measured on a micron scale. We want them to be green. These are all green. And then the ganglion cell maps. I talked before about the ganglion cell complex, how it's made up of 3 layers of the inner retina, and they house the ganglion cell dendrite cell bodies and axons. So if there's an abnormality affecting the nerve, it would make sense that the ganglion cell complex would be affected. But interestingly enough, in this patient, the eye wellness exam is not identifying a problem with the ganglion cell complex. So we talked, again, this is just a schematic of the ganglion cell complex, and again, it's not being affected in this patient, even though we're suspecting an optic nerve head disorder. So let's compare the eyes. Here's a patient that has a normal printout, and essentially there shouldn't be any asymmetry on the OCT because both eyes are normal. But if the patient had a unilateral problem, perhaps we may pick up something on the asymmetry correlate. So it's always nice to be able to compare right to left and vice versa. So here's the conundrum, right? The GCC, the B scans, and the retinal thickness map are all normal. But this patient is a very good historian, and they're telling you that their vision in their left eye has not been normal. It feels funny. They've been experiencing recent headaches that are different than what they've ever had before. Okay, so at this point, we can't sit back and say, well, everything looks fine with your GCC, with your OCT. We're going to dismiss you. We need to move forward and get more testing. Okay, so here we're going to do the ancillary test. We're going to start off with the visual field. And I always like to start off with the visual field in a patient that we suspect may have an optic nerve head problem because it gives us great neurological information. And the optic nerve is part of the nervous system. Okay, so we want to look for any neurological cuts or neurological problems that the visual field can pick up for us. So here's a picture of a Humphrey visual field on this particular patient. The right eye looks fine, but look at the left eye. The left eye shows an enlarged blind spot, okay? And this patient was complaining about a problem in that left eye. So perhaps this enlarged blind spot is giving us something or some indication of what's going on in the back of the eye. So now that you have this information, we're going to go ahead and get the fundus photo, okay? Because now we see there's an enlarged blind spot in that eye, and we're curious to know how that correlates with the fundus image. Okay, so here we have our eye wellness scan, okay, our screening scan, which was normal, and now we have our fundus image. And what's going on with that fundus image? You can clearly see that this patient has some type of swelling going on in that eye, okay? You can see that it looks bubbled, it looks full, it looks heaped. And that would correlate with that abnormal visual field, right? The enlarged blind spot that we found on the visual field. So now that we have some idea in our head of what's going on, okay, we know that there's swelling, we know that there's an enlarged blind spot, we know that the ganglion cell layer hasn't yet been, or the ganglion cell complex has not yet been affected. We're going to move forward with the exam and get more information. So here's our slit lamp assessment. Okay, we're going to check pressure. Again, we're not expecting with optic disc edema, unless there's something else going on at the same time, that the pressure would be affected. Okay, we're going to look at the anterior segment exam. Why is this so critical in a patient that has optic disc edema? Because we never think about those rarer conditions, the inflammatory conditions that can cause a patient to have cells and a swollen nerve, right? So the anterior chamber and the vitreous are crucial in making a differential diagnosis, right? If a patient has syphilis or toxoplasmosis and many others, that's going to affect both the anterior vitreous, the posterior vitreous, and aqueous, okay? So that's the emphasis really of the slit lamp examination in a patient that has optic disc edema. And then we can always look at the lens as well for any evidence of anything going on that might be out of the box. And if you don't recall what cells in the anterior chamber look like from school or from clinical practice, I put a picture up there. Then we go ahead and we move forward with our specialized OCT testing. The screening exam did not give us any abnormal data, but we clearly know at this point that the patient has something abnormal going on. We know that the nerve is abnormal, and we know that the visual field was abnormal. So now we want to move forward with the exam and get more specialized testing. So we're going to start off with that 3D optic nerve head printout that we talked about when we started with the diabetes lecture. Okay, this gives us information about the peripapillary tissue. Okay, and in a normal nerve, you should see that U-shaped pit or contour that you see on these scans. That is what you find in a normal nerve. What happens now in a patient that has disc edema? What's going to happen to that peripapillary tissue? So here's our patient, okay? If you recall, her right eye wasn't affected. The right eye, the field was normal. And when you look at the OCT scan, you can clearly see normal peripapillary tissue. You can see the rim, that contour, that U-shaped contour is present and normal. In the left eye, which is the not well eye, or the swollen eye, you can see there's elevation of that peripapillary tissue. And you can see the loss of that U-shaped contour on the B scan. So if you look at the image on that bottom right, see where my arrows are pointing, that tissue on the sides of the nerve is humped up. You can see a little V shape in the middle, which is supposed to be the normal nerve contour. But we're missing that contour. This is substantiating or confirming the presence of a swollen nerve. How can we use en face in optic disc edema? Okay, we've talked a lot about en face. We've talked about how en face provides almost a Z-cut, where if a B-scan provides a cross-sectional image, the en face provides more of a slice-by-slice image, as if you were standing on top and looking down from the top. Okay? So how can we use it in diseases of the optic nerve head? Right? We know we can use it for sure in the vitreous, but remember that the nerve is attached to the retina, and so if we can slice down to issues of the retina, we can slice down and see the nerve as well. So here's your patient. We're looking, if you look at the image on the top left, you can see that we've checked out, we're clicked on the en face box. The en face box means that we're standing on top of the retina and we're looking down, meaning if it was a normal nerve, we would see no elevation. The nerve would be sitting directly on the retina. But what about a situation like this where the nerve is swollen? Well, clearly, when you look at it, it's going to look like a mushroom. And that's what that en face is pointing out to you, that that tissue is so chemotic and so swollen that you can see a hump there. It highlights the extent of the elevation that you're seeing on the B-scan image. What else can the OCT tell us? What if you weren't sure, okay, if the patient really had disc edema? What if you were thinking maybe it's a pseudopapilledema? Well, we need to look for the V sign, okay? When you do a scan, a B scan, through the optic nerve, if it's true disc edema, you're going to see fluid. the fluid is going to image like a V, which means that there's been a separation between the deeper retinal space and the more superficial retinal space. And that fluid is separating those tissues. And that's what that V sign indicates, because you would not have that in a patient that had a pseudopapilledema. Here's an example. The picture on top is a patient that has optic nerve head drusen, which we call pseudopapilledema, right? You can see that there's a very irregular, if you want to say, contour of the nerve tissue. It's a lumpy contour, okay? And you can also see that on the sides of the scan, there's an abrupt end where the nerve drusen end. The picture on the bottom shows the discedema, where you can visualize that V pattern, which separates the tissue, meaning there's fluid in there, making it appear like a V shape. You can also see that the tissue is more smooth. You don't have that lumpy, irregular border on the inside, which correlate with the optic disc edema. Now we move into some more assessments on the OCT. Okay, we talked about the 3D optic nerve head. Let's talk a little bit about the RNFL. What can the RNFL show us? Okay, how can it help us in our diagnosis of these patients? We can do a few things. We can do a hemispheric analysis, which essentially compares top to bottom, or hemisphere to hemisphere. We can also do a T-SNP tracing. The T-SNP tracing shows you each section of the nerve and how the rim tissue in that section compares to normal, okay? So if you look at the top images, those are our RNFL images. There's a couple things to look at, so let's talk through the scan. The first thing is the color ring around the outside border of the circle. That is the nerve fiber layer analysis in microns. Each section of the RNFL is given on a micron scale. If the number is normal and it matches the age-related norm, it's going to be green. If it's outside statistical significance, it's going to be highlighted as yellow or red. If you want to actually look at the thickness numbers in microns on a color scale, you have to look inside, the contour of the nerve. That's where you see all the different colorations. Blue meaning flatter tissue, red meaning more elevated tissue. Okay? It's normal, superior and inferior, to have red in the peripapillary space because that's the thickest tissue. So we would expect those two wedges, if you look at the right eye, that's what norm looks like. Okay, you can expect that red, superior and inferior. Look at the left eye. We're going to talk about it in a minute, but that left eye has that hot spot all the way around the nerve because it's swollen. So instead of the tissue being thicker where it should be, it's thicker all the way around the nerve. Okay? And then you can even compare the numbers in the areas there, one eye versus the other, to look at the thickness that you would see in the abnormal eye versus the normal eye. And then finally the T-SNP maps, which again, we should have the thickest tissue, superior and inferior, which means that you should have a double hump going up superior and inferior on your T-SNP map. You can see on your right eye that the black line, which is essentially this patient's nerve fiber layer, falls exactly in that normal green space. In your left eye, you can see that the tissue comes outside the norm. It's into the white, which means that it's thickened or elevated. So that nerve fiber layer is elevated because the tissue, the actual nerve substance, the nerve tissue, is elevated. Here I just showed you when you compare number to number, you can see how elevated the tissue is or how thick the tissue is in that abnormal left eye. Here you can see that when the machine goes to draw the nerve, when the OCT goes to draw the nerve, the right eye drew a nice nerve, that's the light gray, but on the left nerve, there's no cupping detected. The nerve is so swollen that the machine can't even trace an optic nerve head, okay? There's an absence of a cup there. And yet something else, we talked about this before, that red color in the peripapillary space indicating there's swelling all over. What about the GCC? We looked at the 3D optic nerve. We looked at the RNFL. What about the GCC? This patient's tissue, we've seen it on many scans, is thick, right? The tissue is outside norms for thickness. So when you think about the GCC, we said initially that we want that GCC to have that nice green donut around the fovea, okay? The fovea doesn't have ganglion cells, but the most ganglion cells are around the fovea. That's what we want it to look like. If a patient has swelling or thickness of the tissue, there's not going to be an abnormality of the GCC. It's telling you that there's a ton of elevation or thickening in that area. That's why this scan is not picking up any abnormality on the GCC. It's symmetric between the eyes, okay? No abnormality. Then you take all of the information that you have and you put it together, okay? We look at the rules of symmetry. We talked a lot in the systemic conditions, how we would expect bilaterality, okay? So in this particular case, we don't have bilaterality. We have a normal nerve in the right eye. We have an abnormal nerve in the left eye, disc edema in the left eye. The rest of the pole looks fine. Remember, we always have to look at the macula. What if the patient had malignant hypertension and they had a macular star, okay? Can't just look at the nerve. You have to look at the whole image, okay, and make sure everything else looks kosher and normal. So here was that rubric that I presented. Okay, we start off with the patient's personal history. We go through all of their medical conditions and what are they complaining about, okay? Recent onset headaches, recent onset nerve problems, color vision. What is their issue? What are they dealing with? Are they having the whooshing in their ears? We go through family history. Again, we're not expecting the family history to have a huge impact here. We get the screening OCT. It didn't give us that much information in this particular patient. We get the non-dilated images, and finally we see, along with the visual field, that the patient had a swollen left nerve. We do slit lamp to confirm that there's no evidence of any inflammatory markers. Okay? No uveitis, no vitritis, because that would lead us down a completely different path. Then we sit down and we get all of the specialized OCT testing that we wanted. We looked at the 3D optic nerve head. We saw the V sign and the loss of the contour of the nerve. Okay, we looked at the RNFL, which substantiated that thickening. We saw the T-SNP, how the map went outside the normal limits. And then we looked at the fundus exam to make sure that there weren't any other findings that might lead our diagnosis in a different direction. And then we put everything together and we make a decision regarding the patient. In this particular patient, it was a unilateral disc edema. So if you recall from the beginning of the presentation, I showed you this kind of outline of a unilateral disc edema and how we would handle it. And these were the differentials, or the main differentials: optic neuritis, an ischemic optic neuropathy, an orbital tumor, or the miscellaneous ones. And we need to look at the critical things here. What are the critical items that we need to consider in a unilateral disc edema? We need to get an MRI of the brain and orbits, right? We need to make sure there's no demyelinating disease. Okay, perhaps we need to do the scan with gadolinium, okay, to rule out demyelinating disease. We also have to make sure there's no orbital tumor in a unilateral case. Patient's age, we said before, optic neuritis affects a certain subset of the population, 20 to 40 females most often, where ION would affect elderly patients. Okay. Gender, optic neuritis would affect females more than men. Rapidity of the onset, okay? Some of these happen quicker than others. Does the patient have a visual field defect? Does the patient have pain on EOMs? Pain on EOMs would go more with an optic neuritis. Does the patient have a proptosis, which may indicate an orbital tumor? Okay, so the workup is a very systematic workup, probably starting off with blood work and MRI, and moving forward down the line depending on what we get. So let's go through a case example of a patient, of one of my patients that had optic disc edema. This was a 31-year-old obese female who came in complaining of headaches and transient visual obscuration. She told me that she just noticed that her vision doesn't seem right for about 6 months, but she couldn't recall the exact amount of time. She had ringing in her ears also, but that's long-standing, Dr. Rodman. It's been about a year, okay? She's very, very obese. She's depressed. She told me that she struggled quite a bit with her weight, that it fluctuates all the time. She's on and off diets. She's 20/20 in her right eye, 20/50 in her left eye. Okay? The rest of the entrance testing is normal. Her chamber is normal. Here's her fundus photos. Okay? She's got bilateral disc edema. Okay? Here's a situation that probably has been lingering for a while, right? She's been symptomatic for a while and finally decided that it was time to come in and get checked out. Okay? Here's your OCT. This is a serous printout. Okay, we've done a few serous printouts. Let me talk you again through the printouts and you can appreciate how abnormal they are. So the top two images on the left show that T-SNP map. Remember, the T-SNP map should be thickest or double hump, inferior and superior, okay, where the tissue should be thickest, but it should stay in the green zone of normal. Hers go outside that green zone of normal, okay? The white, the lines or the graph is out into the white space, which means that the tissue is extremely heaped bilaterally, okay? The third picture overlaps the left and the right eye. This patient has bilateral disc edema, so we wouldn't anticipate that that graph should be very different. They respect each other because it's bilateral. The pictures on the right show that there's no contour of that 3D optic nerve. Remember, we talked about that nice contour that we would expect on the optic nerve. So you can see there's an absence here because the tissue is so swollen. So this image, this plate here, this printout gives us so much information as far as the thickness of the tissue. In fact, the right eye probably looks even thicker than the left because when you look at the hemispheric analysis, you can see that all the numbers are white, whereas in the left eye, we have one sector that's actually green. Okay, so a lot of disease here, a lot of elevation. The visual fields confirm an enlarged blind spot bilaterally, okay, due to that swelling of the tissue. So just as a quick reminder, when we're dealing with bilateral disc edema, this is the rubric or the outline that I like to think of. The patient doesn't have malignant hypertension, so we can rule that out. The patient doesn't have diabetes, so we can rule that out. So we're basically focused on the middle of the slide, papilledema, okay? And I said before that papilledema has many branches off of it. We need to start off with an MRI, because if the MRI is normal and there's no space-occupying lesion or reason that the patient has bilateral swelling, then we can almost move off and go into our diagnosis of pseudotumor. Okay, we want to make sure that the intracranial pressure is normal. And if it's not, then we know that it's papilledema. Okay, but that MRI is going to tell us whether it's an idiopathic intracranial hypertension or whether there's something that's causing it. Okay, this patient had a normal MRI, so we ruled out essentially papilledema. The lumbar puncture was performed. It confirmed an elevated intraocular pressure, 500 millimeters of water, but the CSF was a normal composition. So the diagnosis was increased intracranial hypertension, and the patient was referred to neurology for a workup and a treatment. The patient was started on acetazolamide or Diamox, 500 milligrams, and encouraged tremendously to lose weight. Okay, so all these conditions are going to have increased intracranial hypertension, but or increased intracranial pressure. But the important thing is to make sure there's nothing in the brain that's causing that increased intracranial pressure, and to make sure that the cerebrospinal fluid doesn't have any dangerous components to it. And if all of those are normal, then it's an idiopathic intracranial hypertension or pseudotumor. A similar case example, a 33-year-old black female complaining of fluctuating vision in both eyes for a week with recent headaches. And again, headaches not normal. Okay, she knows there's something going on that feels different than normal. She's a diabetic and she's a hypertensive. Okay, so unlike our other patient who was obese but didn't have those medical conditions, this patient does. This patient's also obese, 320 pounds, her BMI is 54.92. Okay, she's of childbearing age, she's young, her vision is 20/30 in both eyes. Okay, but everything else was unremarkable on the exam. So we get our screening OCTs and photos here. You can see the pictures on top are the B scans. We're missing that normal contour of the nerve due to heaping of the tissue. And when you look at the photos on the bottom, you can similarly see that it's bilateral disc edema. Okay. If you look very closely, you can see especially on the left eye the V sign. Okay. So again, before you even see the patient, you have some sort of idea of what's going on. Diabetic, hypertensive, obese, childbearing age, bilateral disc edema with a V sign. We get her visual fields. Her left eye looked fine, but look at her right eye. She definitely has a defect there. Okay, is it or is it not correlated with what's going on? Most likely it's correlated. Okay, but her left eye doesn't have any defect. Looking more closely at the nerves, you can actually see the extent of the involvement. Bilateral hyperemic swollen nerves. Not only that, but the retinal veins are dilated and tortuous. That's pathognomonic with a papilledema, okay? The bilateral engorged tortuous veins. Because in some conditions, you get flame-shaped hemorrhages like you would with an ION, but when the veins look like this, it's more associated with a papilledema due to that increased intracranial pressure. Now we get more advanced testing. We go ahead and we do our GCC analysis. And if you recall, the patient that I presented way at the beginning of the presentation, the GCC wasn't affected. It was a unilateral disc edema, and the GCC was normal. In this particular patient, the GCC is not normal. You can see that the green donut is kinds of present, but there's areas there of elevation, areas of abnormality on the thickness map. And you can see there's areas of abnormality on the significance map. Okay, so this patient's ganglion cell complex is being affected. The dendrites, cell bodies, and axons of the ganglion cells in this particular patient are being affected. Okay, so maybe this patient has been going on for longer than the other one. Maybe the ganglion cells have had an opportunity to react to the damage of the nerve. So we don't necessarily correlate, again, the GCC findings with what's going on because we don't know about the chronicity of the situation. Okay. Here we look at the RNFL map, which we talked about before. The ring around the outside shows us the statistical significance. Most of it's green. Again, elevated tissue. It's falling in the norms there. It's saying, oh, this patient's got a lot of tissue. Okay. And then you look on the inside to look at the thickness of the different sections. And remember, we want to see the red color superior and inferior. But in this patient, you can see the red all around the nerve, all on the peripapillary space, because the tissue's elevated all over the place. There's an absence of a cup. Remember before we talked about it can't find a cup because the tissue is so swollen. And then when we look at the T-SNP map, we want that, again, double hump, highest superior and inferior, to fall within the green. This patient is falling into the white because it's so elevated. If you look at the parameters that the OCT provides, it shows you here that it can't even pick up a cup, right? Cup is 0.00 because the nerve is so swollen. There's so much edema, it's not discerning a cup. Disc areas are small, they're small discs. Small crowded discs, they're swollen crowded discs. So the summation of this patient, recent onset visual disturbance, ringing in the ears with a different kind of headache again, history of hypertension and diabetes, and it's important in these patients not only to assess for all the things we talked about like the MRI and the intracranial pressure, but to make sure that the blood pressure and the diabetes are under control, because remember that those in themselves could cause bilateral disc edema. She's an overweight female. She's got normal vision, which we would expect with papilledema. Her color vision is normal, which we would expect. Her pupils are normal. She had a slightly abnormal GCC on specialized testing. Her RNFL was abnormal, and she's got that bilateral asymmetric swollen discs with the dilated tortuous veins. So the workup again, we have to get the scans of the brain, we have to get the lumbar puncture to check for the intracranial pressure, and we always want to get a full medical workup, okay, which I might not have mentioned in the other case, to make sure that the patient's CBC, everything's normal, okay, that they don't have any inflammatory markers that would lead to one of these miscellaneous factors, one of these inflammatory diseases. Okay, so the final diagnosis in this patient was pseudotumor. An MRI was done of her brain, which was normal. ruled out any space-occupying lesions. She had a normal CSF constitution, which means that everything inside the CSF was normal. However, her lumbar puncture was abnormal. It was greater than 250 millimeters of water, okay? Which again would go along with that diagnosis of pseudotumor. Okay, so what do we do for her? What's the treatment? Again, talk about weight loss. It's huge. Get her on a diuretic, acetazolamide, Diamox. Discontinuation of any causative medication. Make sure that her hypertension and her diabetes are in place. And in the worst case scenario, they do optic nerve sheath decompression surgery, which she did not need. She actually did very well. She got on medications and did much better. So act quickly with optic disc edema because it could be very serious. And patients that linger around for longer periods of time tend to not have as good of a prognosis as patients that we take care of emergently. Work with a neuro-ophthalmologist, get the imaging, get the blood work, get a lumbar puncture, okay? And if you have the time and the capacity, use your OCT to confirm the diagnosis. If you have a patient that has optic disc drusen and you send them out for all this testing, you're not going to be well liked. So use your OCT to confirm that it's true optic disc edema, and then work with a specialist to take the best care of the patient.